I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Welcome to this episode of the IDD Health Matters podcast. I have with us today our special guest, Dr. Maulik Trivedi. Welcome, Maulik.
Thank you, Craig. Thank you for having me.
Yep. So, we're talking about health, wellness, general supports and services for people with intellectual and developmental disabilities here. Tell us what you do in that realm, in that world.
Well, so I am a physician also by training, practicing emergency medicine for over 20 years in the New York area. And the reason I'm here now is because about 2017, founded Station MD. And Station MD really is an organization that is devoted to elevating the quality of health for individuals with IDD. We happen to use telehealth to deliver that care. And our goal is really very simple, and mission is to really improve the quality of life by allowing these individuals to get access to the medical care that we felt they weren't receiving by qualified physicians who really understand not only their clinical needs and nuances, but also the non-clinical needs and really understands this population. But that's how I got into the field really, like I said, what is that now, 6-7 years ago, because we saw a need.
So what prompted you and your colleagues to decide to start this company?
Yeah. Well, very interestingly, it probably was started out of our own ignorance and lack of understanding. As I said, I work in an emergency department, and for those of your audience may know or may not know, oftentimes by default, individuals with IDD, whether they're in their own home or group home, they end up going to the emergency department for things they shouldn't be going for.
Examples?
So very simple things like cough, fever, medication refills, because one, they don't often have very robust medical care. Even if they have a primary care doctor, that doctor isn't always available. They may not have office hours, and by default, they're like, I'm not sure what's going on, go to the ER. So they would land in the emergency department, and a typical scenario would be they would come with maybe a DSP, a direct support professional, who may or may not know them, with a big binder, that phone book looking.
Lots of information. We really...
Yeah, we don't know where to get information.
Yeah.
But more importantly, I didn't feel comfortable as a physician understanding this population. And you and I have talked about this. There's a gap in medical education. They don't teach you about this population. So number one, you don't feel comfortable. Number two, it's traumatic for anyone to be in the ER. But for this population, bells and whistles, and if you have sensory issues, some of these individuals are nonverbal. It's a terrible place to get care. Let's put it that way. And that was really how our organization was born. We're like, look, there's got to be a better way to treat this population. And at that time, one of the emergency departments that we were working at was very close to a few group homes. Mm-hmm. And so we actually partnered with the state of New York for what's called a DSRIP grant, Delivery System Reform, something, basically something how to make the health system.
There's a lot of letters in this field for sure.
Yes, there is. And so we were awarded this grant to care for this small population of individuals. It was like 40 people. But it was so impactful, so powerful. And really, that's the issue here. The goal is we change lives. I mean, something that would have taken 7 or 8 hours in the ER, transporting them a day or two to recover, we would handle in 20, 30 minutes.
And when you talk about that person going to the ER, oftentimes that involves other people to be involved. If that person they will usually have a support person, so a direct support professional.
Correct.
And then sometimes that direct support professional would have other responsibilities. Now they're going to the emergency room. So what you might see is the provider agency has to find someone else to provide the support for others, or sometimes they may even have to bring other people with them because there's no one else to provide that support. So it really impacts not only the person with the disability who needs the medical care, but the staff, the provider agency as well.
Absolutely. And I mean, you basically nailed it. And, we all know that, if there's an issue for provider agencies right now, it's staffing.
Sure.
And that hasn't changed for years. It's just gotten heightened. But you're right. So an individual has to go. And we've worked with some agencies prior to us implementing our solution where if one individual went to the emergency department or urgent care, everyone got in the van because they're so short. But you're right. They have to fill that person's spot that took that person to the emergency department. If that person's in the emergency department for hours, I've even heard nightmare stories that if the individual got admitted, the hospital asked the DSP to stay with them, which is ludicrous if you think about it, but that's how poorly this population's understood and cared for. But yeah, it's a big issue. And this solution really solves that, allows people to stay in the least disruptive setting, most comfortable setting for them, and that's their home. The other thing is not just for agencies, but for families. For someone to take 6 hours out of their day and take their loved one to the emergency department, a lot of this population has other jobs, they have 2 jobs, and so it's a burden for everyone, for sure.
Sure. So certainly, it's pretty clear that for the person themselves, if they can avoid an emergency department visit, say for simple things like to get a med refill or whatever, that can certainly be impactful to their own lives. But the impact is even greater than just having access to good health care. It actually can save healthcare dollars as well too, right? And I think we have some statistics on
yeah. And we've been doing this now for, like I said, 6-7 years. And so one thing I want to make really clear is we are a 24/7 resource that's available via telehealth. Very easy to use. It's an app. There's no expensive equipment or anything. But sure, we can handle those emergent issues, but we are there as a resource for any medical question, any concern. And you know very well, and everyone knows it, things that may seem insignificant in this population are real issues. Constipation turns into bowel obstruction. A minor UTI turns into urosepsis. A cough could be aspiration pneumonia. So we want to be called. Those little things, if a person misses a medication, well, if it's a vitamin, it's not a big deal. But if it's a seizure med, it is an issue. So all those minor issues, we are there. For COVID, it was a huge thing.
I'm sure.
Right? When someone left and they were exposed, they come back. Do they need a test? Can they be in the same room? If they get a test, is it an antigen? We as physicians even struggle with this.
Sure. Yeah, the questions are pretty challenging.
Yeah.
Especially when we didn't really know all of the details.
Yeah,
right?
yeah. So my first pandemic, and yours probably too.
Mine too.
Yeah.
But I have to say, I was really glad I had retired from my clinical practice before that happened.
Yeah, it was a tough time. Yeah. But in essence, as that resource we serve, to really kind of form a kind of a backbone of care. We're not there to take over the primary care, there to augment what they do. But
yeah, that's a concern, isn't it?
Yeah.
Some clinicians feel like, well, you guys are going to come in and take over primary care, but that's not your goal.
No, it's quite the opposite, if anything. Once they understand that we understand this population, last year we did 32,000 virtual visits just with people with IDD. So we have a lot of experience. We do grand rounds. But to get back to your main question, is having that backbone of care and addressing the medical issues for this population, it of course keeps people out of the ER, which is expensive. Transportation was expensive, hospitalizations. But because that constipation didn't turn into bowel obstruction, that is a significant impact to the individual first and foremost, but imagine the cost savings. And they're huge.
And those things are kind of hard to figure out. Well, what did you prevent? But I can tell you from my standpoint and my experience and knowing what you do, I can guarantee you've prevented many, many, many bad outcomes for people. And that could also, use up a lot of resources as well.
Absolutely. Yeah. And so we have a few quantified studies. From an agency perspective, they have shown a return on their investment simply because of what we discussed, the overtime cost and transportation costs, just that alone. But on the medical side, the savings are in the millions of dollars for a small subset of this population because they're high utilizers and they're using the most expensive parts of the system, right? ERs, hospitalizations, they're complex.
And not necessarily getting the most efficient or best care during those types of visits.
Yeah. Well,
not intentionally.
I'm comfortable saying it as an ER doc because I was that guy. I was the one giving them poor care. I was the one racking up the dollars. So,
And describe what you mean by that. So a person comes in and you're not familiar with a person with disabilities and they're having this change in their behavior. What would be...
So I'll paint the picture, and this is not a hyperbole, this is real. So you have someone comes into the emergency department. Let's say they have a fever. And you have a busy emergency department, 25, 30 other people. You go into the room and all you see is fever. You don't know anything about it, 24-year-old. Like, so what's going on? That person may be nonverbal, maybe has a peg tube, may have some other issues going on. The DSP may or may not know them and hands you that binder, and I don't know where to find anything. It's scribbled.
Sure.
So I'm like, is this person always nonverbal? Did something happen? Did they fall? Like, is it a cough? Do they always have a cough? I order blood tests. I may order a CAT scan. I get everything back. I'm not sure what's going on. Does he always have this scarring in the lung? I don't know anything about that individual because I can't find that. So by default, I've ordered all these tests. They've spent hours in the emergency department, and I'm not comfortable sending them back in the community because I'm not sure if anyone's going to follow up with them. So I'll admit them. And this person maybe has a bronchitis. I'm giving an example,
Sure.
or a cellulitis or something minor that could easily be treated without them going to the ER.
They may even get admitted.
Yeah, and that's a great point because for me as a physician, from a liability perspective, it's much easier for me to admit them to the hospital. At least I know someone will watch them, someone will care for them. God forbid I send them back to the group home and they turn septic, and no one's there to follow up on them. So for me, the safest thing is let's just keep them to the hospital. Not the best thing for the individual, by far the most very expensive proposition when you're talking about that. So, and I don't want to paint the picture that there's not a reason ever to go to the emergency department. There is obviously
There
reasons.
absolutely are
Right.
reasons to go to the emergency department. And, the picture we're painting here is not ideal. It's not the best, but it's what's happening out there, which
Yeah.
is one of the reasons, we advocate so much for
Absolutely.
better trained clinicians so that they understand how to provide healthcare for people with intellectual and developmental disabilities, understand the differences in the ways people might communicate and how behaviors many times are underlying or indicators of some underlying medical condition that's treatable. And it's so important that really, that this becomes part of education for all health providers. That's my platform. That's what I talk about all of the time, and it really is very important to me. Now, you talked about, all of the tests that people might end up getting that they don't necessarily need, or a hospitalization. I know that you have some pretty good statistics on the people that call you and how many of them actually end up needing to go to the emergency department.
Yeah, so this has been pretty consistent through the life of our organization and since we've been doing the work. We are somewhere around 92%, and that means that 92% of the calls we get, we are able to address that medical question and concern and keep that individual in their home setting. So 9 out of 10 times, you don't have to go anywhere. Now, that includes all calls. That could be a call for a medication refill. That could be a call for a minor fall. But in general, most times we're able to keep that person in that home setting and not send them out, which is really impactful, first and foremost, to that individual and the agency and the family. Not having to leave to get simple things addressed is huge.
Sure.
And then, of course, you can extrapolate that into the costs that are saved because of that. The other thing I'll say is that we are not a static. You may call me and say, hey, I have a cough or some little bit of trouble breathing. I may say, try this intervention. We can e-prescribe. We can do everything virtually. We have vital signs. And I'll say, try this, try an inhaler. And I'll call back in an hour. And then I'll call back maybe in another 2 hours. So it's not a once and done. You've seen the doctor and that's it. If that doesn't resolve, you have to go. We follow up with the individuals. We provide full documentation of our encounter. So the agency has all of that. We have an aftercare nurse that'll call the next day and they will say, how is that individual doing? Did you get the medication filled? So it really is a way better way. A lot of times people look at this as a substitute to being seen in person. And I oftentimes think this is far superior than a substitute. This is better care because you're seeing a clinician that knows you, because you have information. We have documentation there. Mm-hmm. You're seeing a clinician that's trained by yours truly. And we all go through a course and we understand. But the other thing is, like I said, we did 30,000 plus visits last year. We've probably seen it before.
Right.
You want to go
experience.
Yeah, you want to go to a clinician that's experienced in this population, and they deserve that at the very least. They need to be seen by someone who understands their needs. So it's huge.
And you talk about access to telemedicine. I think many people out there like telemedicine and like the opportunity to contact someone. Maybe they're sitting at their desk and they can do an office visit during the day instead of having to go out. And so we talk a lot about health equity here, and that's just making something available that many other people have available, for people with disabilities want the same types of things.
Absolutely.
So, I tell you, in the whole health equity picture, I always like to talk about, or ask guests to talk about 3 things in 3 minutes that they would tell listeners, tell the audience about either, the field or things that they can do in their own lives that you think can improve health equity, health and wellness for people with intellectual and developmental disabilities.
3 minutes?
3 minutes.
Okay. I can use 3 hours.
Secret, I won't hold you to it. So go ahead.
So discussing health equity and access, and specifically to this population, I sit on several health equity panels that talk about providing access to individuals that are poor, people of color, people that are in rural areas. And it's very important to discuss that. And usually at the end of the conversation, I'll raise my hand and say, well, what about people with disabilities? And, guess what? There's people with disabilities that are also poor. They tend to, be people of color. And
intersectionality through all of those.
Exactly.
Right?
So that access and equity issue is huge. And I think if I were to tell anyone, I would say specifically the telehealth, I look at this as a standard of care that this population deserves. When we talk about health equity and health access, it's very simple. You should have access to a physician or medical care that understands you and understands your need, regardless of where you are, regardless of your socioeconomic status. And you kind of said it earlier, telehealth, if there's any silver lining to that pandemic, it's that telehealth was adopted for many things. And I think the value of telehealth for this population is even greater because of the challenges that we've discussed, reaching a clinician, transportation, mobility issues, sensory issues. So you have this disruptive technology that really addresses the needs of this population. And from an access and equity point of view, it does level the playing field a little bit. As you said, the population's enjoying it. I liken it to, ramps for restaurants. Everyone enjoys restaurants. People with disabilities should, or in wheelchairs should too. So we'll put a ramp. I think you can't just layer on telehealth for people with disabilities. It has to be specific to their needs, geared towards their specific, medical conditions and comorbidities. And that's what we do.
And you got great feedback from people who use the services as well too.
No, absolutely. We actually worked with an organization to survey individuals themselves, making it very simple surveys for people who are nonverbal or visual issues. And over 90%, or I don't know the exact numbers, overwhelmingly prefer to use StationMD and telehealth for their issues than going to an emergency department or whatnot. One of the things we get is like, well, you're isolating people. And that is not what we're doing. We are keeping people at home so they can do what they want. If isolating people means keeping people out of the emergency department for 6 hours, yes, guilty.
Yeah, right. But who really?
Yeah.
Who wants to go to the emergency department ever?
Yeah. Well, I go and work there and get paid, and I don't want to go many times. But yeah, exactly.
All right. So you did do a great job at dodging the question. So what are the 3 things?
Oh, the 3 things.
Yeah, that you would tell everybody. Yep.
So the 3 things I would say is explore telehealth as an option, because I think it is very impactful to the individual first and foremost, but to you as a family member and agency. 2, I would say be an advocate in terms of health education and awareness. You and I have discussed this. This population is always kind of like, oh yeah, by the way, an afterthought.
Well, or if you don't know about this population, if for one reason or another, you really don't know about the population, or you don't even hear about it.
Yeah. Exactly. And the 3rd thing I would say is, and this is not just telehealth, is explore. There are digital technological revolutions going on in general, but the application of those technologies for this population, I think, are huge. These are remote patient monitoring modalities. These are telehealth, what we do. These are digital tools that really help foster community integration and independence. That's the goal, is to have individuals living right next door. There are some really cool things in AI, artificial intelligence, robotics.
Cool and a little scary.
Yeah, definitely a little scary. Yeah, weird actually, but really interesting ways to allow individuals to live their best life. And I think the more we foster that, and the more as advocates push that, because let's just face it, if no one brings it up, to policymakers or payers or whoever may be making the decisions. We are fighting maybe a strong word, but there's a lot of money in healthcare. Hospital associations are powerful, physician groups are powerful. Someone needs to speak up for people with disabilities, and that's the third thing I would say is, speak up for people.
Those are three great things to talk about and for our audience to think about. I want to touch on something, since we're both sitting here as physicians,
Sure.
that we hear on occasion, and it's the term of the medical model, where people say, oh, well, you're talking about healthcare, you're talking about the medical model. And I really want to make it clear that what we're talking about here is the opposite of the medical model. The medical model is really where you see a person with a disability as having a problem that needs to be fixed, and within themselves they need to be fixed. And this is not at all what we're talking about. What we're talking about is growing society, changing the environment, improving healthcare so that people with intellectual and developmental disabilities have the same level of access to healthcare, to competent healthcare, to clinicians that are trained as anyone else.
Yeah.
That's health equity.
Yeah.
Yeah.
Ditto.
Yeah.
I mean, you just nailed it. Yeah. And then you probably hear the same things I hear, is the medical model, and there's a negative stigma to that. It's like,
Right.
oh, you're just focusing on their disability. No, we are providing them with a better quality of life, and that's our goal. And providing those people that support them with access to people that understand their needs. And that translates into a better quality of life, more time to do the things they want to do. I mean, that's part of our mission statement, is to allow people to live a productive life doing what they want, not trying to navigate the system and find care where they don't need to be going.
Well, it's clear that you are doing that, and you're doing that successfully. So how can people reach out and learn more about you and your organization?
Yeah, so stationmd.com, you can go to our website. All the information is there. We are in many states, 22 states, but please reach out to us, and we'd love to talk to you about how we can bring our service and solution to your state, your agency, your family. The website's probably the best way. There's a way to reach us, and look forward to talking to you. Yeah.
Oh, fantastic. Thank you so much for being with me today.
Thank you for having me.
Look forward to doing it again and getting some updates.
Definitely. Thanks, Craig.
Thanks.